So welcome everyone to the hybrid OR at Heart Center Leipzig. My name is Philip, and next to me is my dear friend and colleague Thiele. He's a cardiac surgeon. We lift the heart team and do all of our structural interventions together. What we're going to do now is a tricuspid intervention, a triclip implantation in a patient with massive tricuspid regurgitation. I also need to introduce somebody else to you, which is Jörg Ender. He will not only take care of patients' GA, but also will perform the echo. Tricuspid interventions is all about imaging, so he's the most important person in the room, actually, and he also is the one who has the hardest job. He will guide us through the procedure. And then, of course, we have a great team supporting us with many more. The patient we are treating today is a 77-year-old man who presented to us with worsening of dyspnea in MYHA class 3 to 4. He gained significantly weight recently despite being on high doses of diuretics, and he presented with massive peripheral edema. His past medical history includes coronary artery disease. He had CABG a couple of years back. He also has combined pre- and post-capillary pulmonary hypertension. He was diagnosed many years ago with a sarcoidosis, but at the present is considered to be inactive with no specific treatment. And he also has chronic kidney disease stage 3, and just recently an episode of acute renal failure. Next slide, please. Here you can see this gentleman's echo. Left ventricular ejection fraction is preserved, but you can see that the left ventricle is rather squashed by a large and pressure overloaded right ventricle with reduced right ventricular function. And as said, there is massive, so grade 4 tricuspid regurgitation when applying a 5-grade scheme. Next slide, please. Patient had invasive assessment, coronary angiography showed his severe 3-vessel disease, but patent grafts to Lima and RCA, so no need for treatment there. Hemodynamics, you can see that he has clearly pulmonary hypertension, systolic PA pressures up to 85 millimeters of mercury, but also increased wedge pressures, presumably due to some HFpEF component. So I think that's the finding of pulmonary hypertension is worth a very brief discussion here. There is always a debate whether patients with pulmonary hypertension, whether they can benefit from treating tricuspid regurgitation. Next slide, please. We just recently found that the outcome of treating tricuspid regurgitation in pulmonary hypertension very much depends on whether there is a concordant or discordant diagnosis of pulmonary hypertension. Concordant means that in that case, pressures are high invasively, but also on echo, and then those with discordant, those are patients where the PA pressures are falsely underestimated on echo, and you can see that these Kaplan-Meier curves on the right, they very much are separating those with a concordant diagnosis. They have almost similar outcome to those without pulmonary hypertension. Next slide. And in our patients, you can see that also on echo, high PA pressure, so we would call that a concordant diagnosis of pulmonary hypertension, and that's been associated with favorable outcome. Next, please. So clearly a patient with a very high surgical risk, and therefore heart team decision was to treat that gentleman with a transcatheter approach with a triclip tricuspid valve edge-to-edge repair. And I'll hand over now to Jörg Ender, who will show you some live echo.
Hello. Also from my side, here you see the four-chamber view, midesophageal, with a relatively normal left atrium and left ventricle, a huge right ventricle, with the septum bulging systolic to the left ventricle, indicating pulmonary hypertension, and a huge right atrium. If we look now for the severity of the tricuspid regurg, we have here biplane vena contracta of 1.5 centimeters, which reflects massive TR. And with PISA, we have an effective regurgitation orifice of 0.6, also massive. And we have a severe backflow into the liver veins, as you can see it here. In 3D, you see the vena contracta area, which is 1.2 square centimeters, which is larger than the PISA. That is the discrepancy between 2D and 3D measurements. And here you have the transgastric view, short axis, where you see the septal leaflet here, the anterior leaflet here, and the posterior leaflet here. And Philip Lortz will now present our strategy.
Yeah, thank you. Thank you. These transgastric views, they are very important for tricuspid interventions. We didn't use them for mitral, but we then found that this is very important for tricuspid, and I actually have to say that this is the most important view. What we're trying to do here is to implant two devices. I think it needs two devices to reduce TR. One will go anteroseptally, so connecting anterior and septal leaflet, as shown here in a sort of 2 to 8 o'clock fashion, and then a second device centrally in a 3 to 9 o'clock fashion. Now, this device is called TriClip, very similar to MitraClip, but obviously this has some very specific different features, which are quite helpful when treating tricuspid regurgitation. Can you show the guide, please? So on the MitraClip guide, there was one knob, but now we have two knobs. One is still the bending, and then there's an additional one, which is called S and L knob, and I show you in a second how this is used. And then the implant catheter itself, also a lot of similarities to what you've been used to from the MitraClip, but as you can show here, one knob more on the guide, one less on the implant catheter. What we've done so far, we punctured the groin, we advanced the guide into the right atrium, then now we will advance the implant through the guide and position it above the tricuspid valve. Are there any comments so far?
Yeah, I guess maybe, the one question I'd have is really about the pulmonary hypertension and the RV dysfunction. The TAP-C was 10. You also seem to have a big diastolic pulmonary gradient, Philip. So I wonder, is this a component, a mixed component of pre and post capillary pulmonary hypertension? And do you look at that? Does it make a difference if it's all post capillary versus mixed pre and post capillary?
Yeah, I agree. It's a combined. We do look for that because it is important. To be completely honest, obviously this patient is a more extreme case. And at the beginning, to be completely honest, we weren't too keen to treat those. But with more and more experience, we understood and we analyzed that these patients, they can benefit as long as there is also a post-capillary component. And secondly, as I showed, when PA pressures are also high on echo, this is very important for us, then normally they do quite well. And this is probably a surrogate for still some pressure separation between the RV and RA.
Okay.
Yeah, maybe a surrogate or functional reserve, but I think that the key point here is that you need very specific measurements and assessments, and you have to understand what's going on in the pulmonary vasculature as well as the other systems, rather than just saying that there's torrential TR, so let's fix it.
Totally. We do invasive hemodynamics in all of our patients before we consider them for treatment. Okay, so
Nick, you had a comment?
You can see.
So Philip, one minor comment maybe. You have very nice echo images in this particular case, but sometimes it can be quite challenging to highlight the tricuspid leaflets with TEE, even in the transgastric view. Do you sometimes use ICE or transthoracic echo to help you identify the leaflets?
I think it can be useful, but we don't use ICE. And we very, very rarely use transthoracic. But obviously, when we consider those patients and when we discuss them, we make sure that imaging is appropriate. It makes no sense to embark into a complex intervention without having proper imaging, especially not on the tricuspid valve. Okay, so
go ahead, Philip.
The guide is in the RA. Yeah, the device is out. What we're trying to do now, we're going to steer down towards the tricuspid valve, and for this we use this knob, the flex and extension knob, that is the equivalent to the M maneuver when doing mitral interventions. Okay, while doing that, you can see on fluoroscopy that we slowly coming down, and the same on echo. The other difference to the MitraClip system here is that the bend on the guide is slightly more distal and shorter, and that provides us with some distance towards the tricuspid valve, which is quite handy in these procedures. So, does it talk? Okay, so I think we can go now to an explain view, please. So quite posterior in this case. As you can see here, on the left you have a sort of commissurial view with the aorta on the right and posterior septal on the left. I have to come down a little bit more. We are quite posterior, aren't we? Okay. It's a little bit unusual anatomy here. Okay, now we're getting there. So what's important here is to take some time and make sure that the device is orientated really in an orthogonal fashion towards the tricuspid annulus. And this in two planes, on a commissurial view, as you can see here on the left, and then also on a grasping view on the right. The device is already opened a little bit. No, it is open now, as you can see here. Now, to change the orientation on the left side, we can apply some more or less flex, as you can see here now. When we use less flex, we come towards anteroseptal, more flex towards posteroseptal, and here we would like to have a 90-degree orientation. And then on the right, we can make advantage of that new feature, the septal and lateral knob going septally, which I will do now. And you focus on echo on the right. So the device moves now towards septal. This is hardly ever needed, but what's more commonly needed is to move more towards the lateral position. And by doing that, I can go lateral and I correct on the guide, go septal, and thereby we can achieve a 90-degree orientation. So this is something which was more difficult in these off-label MitraClip cases for tricuspid valve, but it's actually quite helpful, like, very important to have an orthogonal orientation. So I guess this was our plan, and I think we go back to you now, and you can come back to us when we advanced with the procedure. Is that correct?
Thank you, Philip. What we're going to do actually now is we're going to go over to Atlanta, and they're going to show us, and we're going to go back and forth at various steps of the procedure to see how things have progressed. So thank you, Philip.
Good afternoon from Emory, and thank you for allowing us to show this case. I'm Kendra Grubb, and I'm joined by my co-directors, Adam Greenbaum and Vasilis Bablieros, as well as the rest of the team. Today, I have two fellows with me, Norihiko Kamioka and Jose Condado. Jose is our graduating fellow who's going to be presenting the case for you this morning.
All right, next. No disclosure. So we have a 78-year-old female who, with multiple medical problems, including the end-stage renal disease. She had a prior kidney transplant that is not failed, so she's now back on dialysis. She has coronary artery disease and a prior transcatheter aortic valve replacement with a 20-millimeter sapien valve. She has now severe mitral stenosis and is being considered for isolated mitral valve replacement. Her STS score is 11, which puts her at a very high risk. Next slide. So this is her initial echo that shows severe mitral annular calcification with an EF of 40% and baseline moderate MR. Next slide. So in order to consider her for transcatheter mitral valve intervention, we do an assessment by 3D echo on the left that shows 300 degrees of MAC, which is part of the problem for her valve disease, but it also allows us to have some landing for transcatheter valve. And we do a gated cardiac CT that shows that the size of the annulus is 29 by 23, which is big enough to deploy a 29 valve. Next slide. As part of the assessment, we also use our CT scan to evaluate the risk of LVOT obstruction. As we put the transcatheter valve, the anterior leaflet could go into the left ventricular outflow tract and create obstruction. In her case, the neo LVOT is 117, which is a high risk for LVOT obstruction with TMVR. Next slide. So because of that, she is a candidate for a lampoon technique, anterior laceration of the anterior leaflet. We have different strategies to perform lampoon. Next, we're gonna do an anterograde lampoon.
I don't have it.
Next. So procedural plan is to perform an anterograde lampoon assisted with a balloon because of the severe calcification of the anterior leaflet. Perform a transeptal transcatheter mitral valve replacement with a 29 sapien inflated to plus 6 cc's of her nominal size.
All right, well, thank you, Jose. Adam, why don't you catch us up on what you guys have been doing this morning?
Sure. So we are working as we talk because our blood pressure is a little soft. There was a lot of, Patrick, could you show maybe go back and show the picture of the original valve that we were dealing with here? Are you able to show us that? So very, very heavy bar of calcium across the anterior leaflet, which we knew was going to give us trouble on the lampoon. So for that reason, we did put embolic protection in. So there is an off-label use of a sentinel device for a valve and MAC procedure here. She's on dialysis, and all her fistulas are in the upper extremities, so we actually got transaxillary access on the right and put the sentinel device in. We then got all the rest of our access from the leg. There's a large sheath in the right vein for transeptal delivery.
Gotcha.
And we have a bilateral femoral access. On the left, we put a balloon pump in because sometimes in these heavily calcified leaflets, the pressure gets a little soft after the lampoon, so we routinely use a balloon pump. There's a balloon pump on the left. There's a vein on the left for the pacing during deployment. The valve delivery comes from the right, and we had a little additional access on the artery on the left just in case we needed it. So that's our access. Maybe we can go back a few pictures and show the creation. Go forward.
Go forward?
Yeah, maybe we'll go forward, and let's show the creation of the lampoon loop here, just to show you real quick. Yeah, let's go a bunch. Yeah, so here's where we do the transeptal. We put 2 steerable guide catheters into the left atrium for the lampoon. And then what we do is we burn through the base. We line up one of them at the base of the anterior leaflet, and we burn through.
Yeah.
Then we grab it.
Okay, we got some desatting. We need to put this in.
Okay.
And let's get measure us the septostomy. We're going to get going.
After the septostomy, it looks like her sats are getting a little low. So we're going to go ahead and deploy this valve, and then we'll talk some more.
No, wire. Wire.
Adam has it.
I have wire. And if you guys on the panel want to just comment as we start to do this, feel free. But we're going to concentrate on getting this valve in here.
Yeah, get the valve in. We want to watch this, Adam and Vasilis. We just, maybe we could still show the procedure full screen. I think this is a critically important part. We don't want to distract you.
Okay. You want to try and telescope Adam?
You want to telescope the valve? Sure.
Yeah.
Okay. So go ahead and you're unlocked.
Yep, you are unlocked.
So
yeah,
now
I'm
go
not
ahead.
sure. We got to make the way around. See the.
Oh.
Turn this a little bit. Okay. Is it coming?
Well, the nose cone's across.
Yeah.
The question is, what are we getting stuck on here? Are you bent? Are you bent at all?
Yeah, we're bent.
Huh?
Yeah, we're bent.
Yeah.
Okay.
And now try and push it through a little bit there.
Okay. Hold on a second. It's going
So right
completely
now we're
posterior.
just having a little trouble delivering the valve across the MAC here. Patrick, if you could kind of show us what we're getting stuck on.
Keep your wire in, and I'm gonna keep your wire a little bit more apical. Let's come back a little bit. Let's see if we can redo this again one more time.
I think
Watch
you're
your
just a
wire.
little low.
Say what?
Yeah, you're a little flat. Yeah. So I think you want to come.
Yeah, I think we're flat because the septum is.
Yep.
Can you tug a little bit there?
So you're all the way down by the
Yep. So we had the septum got a little trashed during the procedure, and so what's happened is we lost our height, so we're coming flat across the trajectory of this valve.
Okay.
And so looks like our balloon, our nose cone, is getting caught on the mitral here. You might have to just push it all the way in the atrium and go from way high here.
Let's try here.
Yeah.
Okay, let me try this. I think we were. Try to turn it in here, Adam.
So Ajay, you know, what are some tricks that you guys are using at Columbia?
Yeah, so Kendra, you know, I think this shows. Oh, here we go. I think you got across.
Yeah.
No, we're across.
Looks
we
like
just had to do some maneuvers, but I was going to have you guys commentate.
It's a real thin septum, and with the antegrade lampoon, I think with the pull.
Adam, you got wire?
Yeah, I got wire. We sort of made a little bit more damage to the septum than we wanted. So now, if you look at the picture, are you looking at your RAO view? Is that what you see, or do you see both views, guys?
Adam, I'm gonna keep
RAO view.
Yeah, we're getting a little bit of. We're running a little bit here from our wire in the apex. So there's a line of calcium in the middle of our screen.
Push wire. I think we're gonna be good.
Yeah, we're gonna try and get that. We're at an angle of deployment here. We're gonna try and land about 90-10 on that calcium. That calcium is ventricular.
A little bit more wire.
Here, I got wire. I got wire.
Yeah, a little bit more wire.
Yep, pushing wire, pushing you back, pushing you back.
What'd you say?
We're in VT.
Yeah.
Pushing you back.
Okay, we're in VT here. You guys want a shock out of VT? You want a shock out of VT, or do you want to go back?
Just go. Go.
All right.
Okay,
turn the balloon off and hold ventilation. No, we're try. Everybody.
Yeah.
All right.
Okay.
Okay. Yeah, we're just. Looks like our wire is causing a little bit of VT here.
Okay. There we go.
So we're just going to take a second here.
Take your
try
time.
and line it up. We're going to try and get this about 90-10. Remember, the calcium is ventricular, so we want a little bit of this valve above it.
Do you want to hold wire?
Yeah, I'm going to do
you
the
wire
part, and you're going to do that.
Yes.
What we're going to try and do here is push a little on the wire, a little on the delivery system to try and correct some septolateral coaxiality issues. If you look at the valve, we're reasonably coaxial here. It's almost rectangular. Do you think that you want me to come a little caudal and see? Or do you want me to?
I think we're, come a little caudal, so we can square up the aortic valve. Yeah.
Yeah.
Patrick, we should be going straight into posterior. How are we on medial?
How do we look in terms of T? Can you guys see TEE? We're just going to look for some coaxiality. I'm going to push in a tiny bit.
Yeah.
I'm gonna push.
There we go. Okay. I'm going to pull back a little.
Can we see, can you see
Hard to
echo?
tell.
Yeah, you can see echo there.
Yeah,
I
we
think,
see
remember,
echo.
so this valve will,
That's looking pretty good.
Right.
yeah, the valve's going to foreshorten on the atrial side towards the ventricle. We have our mid dot just on the ventricular side of the calcium. I think this is where we're going to go. You guys okay with that?
So maybe
Okay.
you want to come a little atrial. What do you think?
Well, I'll push you back a little
Okay.
bit. So let's hold let's hold ventilation and hold balloon pump. All right, and let's, good. And are we ready on the pacer? Let's pace at 180. Good. Go to 200. Up to 200. I would start to slowly deploy there.
Yeah.
I'm going to let it come down a little bit more
Yeah.
ventricular.
Yeah, a little bit more, Kendra. Come on, Kendra.
Are you pushing a little, Vasil?
I'm pushing
Yep,
now.
good.
Go,
Now,
finish,
all of it,
finish,
every
finish,
bit of
finish,
it.
finish.
Yep,
Okay.
good.
And deflate it.
All right, pacer off. Resume the balloon pump and resume ventilation. We're going to leave the balloon in the septum here for...
Yeah, go ahead. Yeah, go ahead and defibrillate. Okay. Start the balloon pump.
Start the balloon pump. And let's check LVOT. And then maybe square up the valve a little bit and see how we look here. So that was a 29 valve delivered plus 6. If you look at this picture here, we're just a little bit above the calcium. You agree?
The position looks very good, Adam. I mean, I think you landed where you wanted to. It looks
We have a
pretty well
little
anchored.
flare ventricular, which is good. And I'm sorry we had to rush through this. It's just the pressure was looking a little soft.
Patrick, let us know how big this
So we're going to
septum
take a
is so we can start
survey
pulling
of the
device also.
most important thing to look at here is probably the TEE images. We're looking at the height of the posts above the annulus. We look in 4 quadrants. We look medial, lateral, anterior, posterior to see did we cant this valve? Are we coaxial with the annulus? You know, our pressure is much better, which is good. Looks like we may be a little high on that side.
Yeah.
Which is lateral.
Maybe a very small PVL there, yeah.
You know, fluoroscopically, it doesn't look high. The lateral side would be the top of this valve in an RAO view.
Thank you.
Mm-hmm.
Just make sure that's indeed perivalvular. So there's a balloon. That's our balloon right there, isn't it?
Yeah.
Yeah, maybe balloon pump down to 1 to 3 or something.
Yeah.
Yeah, we're down to 1 to 2
Let's
already.
pull the balloon into the septum maybe just for a minute here. Let's just get it out of the valve here. Let's just leave it there.
Coming
Wait,
back.
leave it. No, don't.
Do you want the nose cone out of the valve?
Yeah. I just. Let's
All
take
right.
a look here.
Can you take the
We
balloon
have
pump
a lot
down,
of blood
guys?
pressure. Can we come off the?
Come off the balloon
Can
pump?
we come off drips and things?
Just go to 1 to 3.
And let's go standby on the. Yeah, let's just see
Got
if
lots
we can
of
get
blood
that
pressure.
drug down. Some of this may be blood pressure related.
Yeah, that looks much more stable now.
There's a little bit of central MR from our stiff wire.
So.
How's our saturation?
Blood pressure is great.
Great.
All right. So, Adam, can you show? We were starting to talk about the septostomy and those things. Why don't we talk a little bit about that while we're letting this valve settle in?
Yeah. So as they do their job here, let's talk about this case from the beginning. How much time do we have, Azeem?
I think the case is kind of, we'd like to see the beginning part. So let's stay another 10 minutes with you and then we'll go back to Leipzig.
Thank you.
Okay. So like I said, with a heavily calcified leaflet, we went ahead and put a sentinel device in. We measured some baseline gradients. That's a 20 millimeter S3 that's in there with a peak-to-peak gradient of 12 at the start of the case. And so combination of LVOT and aortic valve gradient was about 12. We'll get some measurements here in a second for you. We went ahead and did our septostomy. We use electricity to get across. This is not a Baylis. This is a steerable Nagari catheter and an Estata wire that we just electrify the tip to get across. And then we drove 2 steerable guide catheters in to the left atrium. So I'm going to go fast forward now. And what we'll do at this point here, so now we're set up to do our lampoon. She actually started to develop a pericardial effusion. We're not exactly sure if it was coming from RV apex or not. So we went ahead and put a pigtail drainage catheter in. So that's what you could see in the middle. But the 2 steerable catheters is the setup for the lampoon. We burn through the base of the anterior leaflet and create a loop. And that's what sets up the lampoon system. So that's a loop that comes from the base. Maybe we can get this one to play here. It's a little hard to say. So what we have here is one catheter that's through the base of the leaflet and the other through the middle of the leaflet. So if we pull, you can see here, this is just the start of us testing the system to pull through the leaflet here. If you look at the eleocaudal view, our system is right under the middle of that sapien valve, so we're right at A2, we're right in the middle, that's where we want to burn, and we're pulling the catheter back into the left atrium, and by pulling on those 2 catheters, we will slice the leaflet. Once we do that, it's septostomy.
So why did you have a balloon on the previous picture?
So in cases of heavy calcium, we are concerned that after the split, if the calcium is still cardboard, if you think of it like cardboard, maybe the splay won't be as much as we would like. So we've developed a modification for both basilica and both lampoon, which we call balloon-assisted lampoon or balloon-assisted basilica, where we take a 4 or 5 millimeter balloon in the anterior leaflet, or in the case of basilica, in one of the aortic leaflets, and we create a hole at the base before we do the lampoon. And by splitting, basically, if you think of it as a T-cut, if we spread the base and then we do the lampoon, we can get a wider split on a heavily calcified leaflet. So we only do that when the leaflet is calcified. So that's the balloon part. We've done about 10 of those. And it looks like when you look at it by TEE, there's a wider split. So then we go on to do the lampoon in its anterograde fashion. And then as you saw when we came live, after the final pull of the lampoon, we did septostomy and then valve deployment.
3D.
A little bit about the valve deployment, if you want to let it loop here, is as you can see, it was a slow deployment. There was a lot of discussion about how to line it up. In the middle of this deployment, you will see Vasily's start to push to help orient more in a medial lateral orientation. Again, medial is on the bottom of our screen, lateral is on the top. So there's the push to help before we inflate it the rest of the way. And then the deflation. So that's a lot of the work that we did before we went live, and then you saw the deployment live. Now we will check final gradients. Let's see, as long as our oxygen status is stable, let's get the delivery system out. Let's check some final gradients for you. Fair enough?
You got where?
I do, if you follow.
No, that looks beautiful. Thank you for going through it step by step. Maybe have our panel, Nick and Lars, maybe make some comments while you're getting the gradients and getting your system out.
Can we see echo on left ventricular alpha tract and see how efficient the lampoon technique was?
Patrick, Patrick, they're asking for LVOT, and we're going to get you both TEE and some hemos too.
Two things. Remember, the septum is still open, and the other thing is that this patient has a 20 millimeter sapien 3, so there was some gradient. We measured a peak to peak of about let's see,
all the way at the end.
Ready?
It was about 15 or so at baseline. So that some of the things that we have to sort of keep in mind, and we're also going to give you an invasive gradient here as well. See what we have. Our starting, let's see. Yeah, we were about 20 or so. Let's see how much we increase the. This wasn't the tightest LVOT that we've treated, but certainly the calcium was very bulky. Yeah.
This one, red. Forward. pull back. Well, let's get blue. Let's get blue out from under here. So what catheter? So now you're looking at LV. Where's our aortic? What do we got?
It's quite obvious that.
There we go.
So Basilis,
put it
so
up
Adam,
here on the demo.
the reason you did an antegrade
Forward
lampoon rather than retrograde was because of the sapien valve in the aortic position. Is that correct?
Well, the initial concept for antegrade lampoon or either apical lampoon was for people with mechanical aortic valves. Azeem, it's become our standard approach now. It's less, you have a lot more control when perforating the base of A2, coming transeptally than retrograde through the aortic valve. So it's if we're going to do lampoon, it is antegrade. If the patient has a protected annulus, in other words, they have a previous ring, they have a previous mitral valve, et cetera, we'll do tip to base lampoon, which is something you may have seen or may have done. Yeah, where the V is we're pulling from an AV rail, and we don't even have to perforate the base of the leaflet. All right.
If you guys can see live hemo, here is our gradient now. Again, there was a baseline peak to peak of 12, and now we're getting 20 or 18. Is that what I see here? So really, it's only gone up by 6. And again, that's with the septum open, so there's still a lot of.
And the heart rate's 122.
And
also,
the heart rate's fast. Our EDP, she's dialysis, and so the EDP is a little high. We're going to check mitral gradient here. We're going to go ahead and check
I think the
mitral gradient, which I don't expect to be high. If you guys want to cut there, and we can come back and say goodbye, and at the very end if you'd like.
Yeah. So maybe what we'll do is Leipzig's ready to grasp their tricuspid, and I think it'll be interesting to see that. We'll maybe come back just at the end to see the gradients and for you to see, what it looks like after the closure of the septum, if that's okay.
That sounds great.
Great.
Right. Thanks, Adam, Basilis, Kendra.
How is your Patrick,
Thank you.
how much PVL and stuff? Do we need to plug it, or is it okay?
Okay, so you're back with us. We still about to, can you hear us? We're still about to implant the first device. And you can see that we have pretty good imaging, and we are very close, but yet it's not that easy. What we see here, we have the device in the central position, we have the anterior leaflet on, and it seems like it's just a tiny move necessary to get the septal on, and we hopefully will manage to do so now. What's sometimes helpful in these procedures is to use the ventilation. So what we're going to ask now is to have a breath hold and also apply some PEEP to it. Okay, the disadvantage of changing the respiration is that we also change position a little bit. As you can see, you see now. So we lost the anterior leaflet.
So Azeem, can I ask you a question while Philippe is working?
Yeah, go ahead, Lars.
So what is the length of these arms on the triclip? It's the same as XT.
Yeah, so you have NT and XT. If the clips are identical, what changes is the actual delivery system. So the actual clip at the end is identical to the mitral, but what changes is the whole delivery system. So now, the curve of the guiding catheter is different. It has a shorter curve, plus it has 2 knobs now instead of 1 knob. Okay, and on the clip delivery system, instead of having the AP in the medial lateral, you just have 1 knob, which is the knob that brings you down onto the valve. But everything else, the length of the clip, the grippers, are all the same. I think the one thing that most of us feel is missing is we'd love to have the G4 for tricuspid. So the ability to maybe independently grasp would be also very useful. So here also you see he's showing us the transgastric view, which is where you do your clip orientation. So normally with mitral, we'd use the 3D to do our clip orientation. With the tricuspid, you use the transgastric.
I think we have both leaflets on now. Can we go to a mid-esophageal view, please?
Yes. Can we interrupt you, please? So both leaflets are on.
Okay, so we have both leaflets. Oh, we have.
Yes, it looks like you have both leaflets there, Philip.
And as soon as we have a stable image, we're going to close the device.
So what did you change to get both leaflets on?
Just tried to improve the trajectory and also pulled up at the right time.
Now we can see that we have a very nice leaflet insertion. So, and also there's some, so the analysis gets much smaller. So this was a perfect grasp.
Can we see some color, please? Yeah. Okay, so it is less, but obviously there's still some TR. Let's assess that on a transgastric view. I'm not sure whether you've seen it, but what we've done here, eventually we got the leaflets on a transgastric view, and this is something we do quite often because it combines a couple of information which are quite useful. You get the orientation of the clip, and you see immediately once you have the leaflets on, you see restriction in motion, and it tells you that the leaflets are on. And if we now change the image plane ever so slightly by going in and out, you can see that there is now an opening between the clip and the anteroseptal commissure. And then in between, we see the two leaflets, the anterior leaflets and the septal leaflets. They're clearly restricted in motion, and I think they're nicely connected with each other. So this looks good. Next step. Yeah.
Maybe one additional information we just got from the hemodynamics, which is also very important. So before we had a clear ventricularization of the right atrial pressure, and now it gets better. So maybe you can show the hemodynamics from the right atrial pressure tracing. So this would be very helpful to see. In addition, for sure, we need the echo for the tricuspid regurgitation assessment, but hemodynamics are very helpful, and so we have online hemodynamic assessment of the right atrial pressure. Can you see it? So can you see the right atrial pressure now? All right, okay. Yeah. So there's significant improvement just now with the first clip.
Right. I think it's important for the audience also to realize with these cases of severe TR, we need often to do multiple clips, but also even if we're able to decrease this from, this is massive TR, so it's beyond severe. If we're able to decrease this even by 1 or 2 grades, these patients do significantly better. And remember, this is a patient that would never get surgery with such severe pulmonary hypertension, severe RV dilatation, and RV dysfunction. Forget all the other comorbidities, but just that alone, this patient would never get surgery.
Okay, so the idea now is to release the device and then implant a second one just on the transgastric view, just above the first. Okay, can we go to X-plane view to show the release?
So Philip, where are you thinking of putting your second clip, posteroseptal or right another enteroseptal clip?
Yeah, the plan is to implant this one in posteroseptal direction of the first, but I guess it will end up still anteroseptally, or what we often refer to as a septomural leaflet. Maybe you can go back to transgastric view while we prepare the second clip and remove this one, and then I can show you what I mean. Another comment about strategy in general. It is important to connect either the anterior or posterior leaflet to the septal leaflet, because what we do other than edge-to-edge therapy, we also get some degree of indirect annuloplasty by pulling over the RV free wall towards the septum.
So Philip, I have a question related to the technique that you're now showcasing. Once you have one clip in, does it become easier the next grasping? So you definitely upfront already told us you will end up putting in 2 clips. So is the second clipping going to be easier, or because of the tricuspid nature, that's not the case?
I'd say yes and no. It is easier in that respect that normally the motion of the leaflets is less. Once you have one clip in, you know exactly where to go. You can make the most out of fluoroscopy, to use the first as a landmark. And no, I mean, if you really have to make sure that you not get entangled into any cords, because obviously there's a risk to dislodge the first one. But in general, I'd say that the second normally is a little bit easier.
You know, the other point, Nicolas, as well is, you know, whereas in mitral, when you know you're going to do multiple clips, we usually say start medial and go lateral. For tricuspid, we say start enteroseptal and then go posteroseptal. Okay, so start above and then go below. And the main reason being is for imaging, is that if you already have a posteroseptal clip and then you're trying to go enteroseptal, it makes the imaging a lot more challenging from the first clip. So we tend to start, like Philip's doing, enteroseptal and then move downwards to posteroseptal.
What is the relative proportion of patients who end up having more than one clip? So with mitral, it's almost 50%, between 30 and 50. With tricuspid, is it more beyond 50%?
About 80 to 85% will get 2 clips or more.
Oh, there you go.
Okay, so very rare patients that you can treat with one clip, in my experience.
Explain view, please. Okay, so we come up with the second
clip design really
second clip.
Facilitated the procedure. You know, we all struggled with using the dedicated mitral clip for mitral device in the tricuspid, and that, you know, from time to time it became impossible to be able to grasp leaflets. I have the impression that with this new technology, your options are bigger and it becomes easier.
Yeah, you know, it'd be nice to hear from Holger and the team. You know, the team in Leipzig, I think, are the first in the world to do a commercial case with this device. And they also have one of the largest experiences with Pascal. So it'd be good to hear what they think about, you know, the triclip versus mitral, and also where they think the role of Pascal is. Holger, maybe, while Philip's working?
Yeah, Philip, maybe you will give the answer on when we use Pascal or when we use the triclip system. So this is... Okay.
I mean, to your first remark, yes, this device and the modified technique and features and steering, it makes the procedure easier. It still requires good imaging. It's still not always straightforward, but it makes it easier. And then to your second question, well, that's something we have to figure out within the next couple of years, when to use which device. When it comes to Pascal device, there is another very specific feature to it, and this is independent grasping. And this is why at the present we use that very often in larger gaps where it is not possible to bridge the gaps with a device where you can't do independent grasping. But that will change with this device as well.
Okay. So Philip, while you are orientating this device and lining it up, we're just going to quickly go to Leipzig to say goodbye to them and see the end of the case, and then we're going to come to you to see the second clip. Okay? Sorry, to Atlanta. To Atlanta.
Leipzig.
Yeah.
All right. Well, welcome back. Thank you. We have successfully closed the septum, and I'm going to have Patrick show you some key images from the case. Dr. Gleason?
Yeah, sure. So we can go back to
Is Dr. Gleason's mic on? Great.
Okay,
Yep,
perfect.
We can hear you.
So this was our initial after the lampoon went through the anterior leaflet here and snared with the second catheter. You can see after they did the balloon modification of the anterior leaflet, the flow coming through that base of A2 there. This is as they were lacerating that anterior leaflet. You can see the very bulky calcification on the anterior leaflet that the catheters are coming around. And then finally, after complete laceration, as the catheters came medially, you can see the split in the leaflets right here.
That's great imaging.
And then obviously a very flail anterior leaflet after completion of the laceration. This is obviously immediately post-valve deployment. There was a little piece of calcification that ended up in the left atrium. This was the residual PVL that we ended up with. We're calling that mild PVL. It's in the posterior lateral corner there. And then this gets into our closure of the septum, which we can show you here. Some final pictures after deployment of the septal occluder.
Thank you,
Patrick. If you could make sure we could see the two fluoroscopic images, just wanted to show you two things. So you saw what we referred to as BA lampoon or balloon-assisted lampoon, and then valve and MAC TMVR. I also want you to take a close look at the commissural alignment. If you look at the iliocaudal view here, you can see the little double piece of metal. Let's see, to the patient's left, or the patient's left on the aortic valve. So it looks like we got reasonable commissural alignment with the transcatheter valve. Maybe you guys can show that on your screen with a cursor or something. And we do that by mounting the pledget at 12 o'clock. And then when we turn the system upside down and drive it in, we've had pretty good luck getting good commissural alignment. Because if you do a lampoon and then you put the commissure of the transcatheter valve right in front of the LVOT, you can run into problems too. If you look at our hemodynamics, again, our peak-to-peak gradient here is about 20. And we were 12 to start, so if you want to call it a 10 millimeter mercury increase on the LVOT with a very calcified stiff leaflet, we would consider that a success. She should feel better. Her mitral gradient's down to almost nothing from a mean of about 14 to start.
And he's off support.
And that about summarizes what we did. Yeah,
yes,
there's no balloon pump. Well, the balloon pump is off. The pressors are off. Oxygen saturation is 100%. Heart rate is starting to come down. So we will just start to remove access. We'll remove sentinel first. We'll give some protamine. We'll get the rest of the access out, and we'll try and wake her up.
Well, and thank you for allowing us to show this case. I think this highlights kind of what we were talking about before, which was the complexity of these mitral cases. And as I mentioned, some of the most challenging ones are the valve and MAC. And so here demonstrated is, a very complex case for a patient who really doesn't have any other options. And that's who we reserve this for. Azeem, I'm sorry to cut you off.
No, all I wanted to say was congratulate all of you, Team Emory, Kendra, Vasilis, Adam, and the rest of the team. I think that was a super complex case. I'm not sure there are many places in the world who could have done this case as elegantly and as well planned as you did. We interrupted you in a very challenging point, but you went through and did the implantation of a very unstable patient. I think you've shown the audience and how you can treat these very complex patients with MAC who are at high risk of alveolar tract obstruction. We got to see a antegrade lampoon that was balloon assisted, a valve in MAC, the evaluation that happens afterwards, and then you close the septum as well. Phenomenal case. Thank you so much. And congratulations to the team.
Yeah, fully agree. Thanks so much, team.
Thank you.
Take care.
Okay,
all right,
so
Philip, we're
you're
back
back
with
with
you.
us. What we've done, we aligned the second clip, and we used for that fluoroscopy as well. Can we see fluoroscopy for a second, please? And we try to be really close to the first device. We went for another anteroseptal position. And what you can see here is, again, a transgastric view. We see the device posteroceptal of the first one. What you can see here, and especially for the second device, the transgastric view is often better than a mid-esophageal view. You can see that both the septal leaflet is on, and here you can see the anterior. Here the septal on the device, and here the anterior leaflet. So what we look for is a restriction in motion, and we make sure that the arms of the device are clearly underneath the leaflet. So we go back to Echo Live, and we will close the device now. We brought down the crippers already, and we will close the device now very slowly, and we watch it on that view to see the leaflets coming nicely together. Langsam.
Yeah, that looks very good.
So Thiele is closing the device, and you can see that the whole anatomy is getting a little bit smaller, and everything is coming together. Can you see that?
So Philip, can we see eye?
Yeah, it's very nice.
See eye pressure.
Yeah.
Yes. Can you put in pressure as well? We are still simultaneously recording. So yeah, you see we have no relevant V wave of RA pressure tracings anymore. So I think we did well in achieving to connect the anterior and septal leaflet together. They're both nicely in. And now we have to see what that means in terms of TR reduction in a ventricle which operates on almost systemic pressures.
Philip, question for you.
Yes.
Some might ask, because of the severe pulmonary hypertension, is there a risk of the RV failing further if the TR goes away?
Well, I guess theoretically, yes, and we discussed that in the past, and we still do. However, having said that, we haven't seen acute RV failure in these patients at all, and this is, it might be due to the fact that we always leave a little bit of exit behind, so we rarely totally abolish TR. Normally there's some degree of TR left, and this is why we rarely see it. In a patient with an RV operating on 90 millimeters of mercury, I would not be worried that that little additional afterload we introduce by performing this procedure, that these ventricles are failing. I would be more concerned in extremely dilated ventricles which cannot generate high pressures anymore. Okay,
Yeah,
so
the stage beyond that where pressures have come down. But go ahead, sorry to interrupt, go ahead.
Yeah, no, it's time now to see what we've achieved. So on color we still see TR, but what is that in terms of numbers? Remember, we had not severe but massive tricuspid regurgitation, and we would be happy to bring it down by 2 grades to moderate. And this, we are happy about that not only because it looks good, because we've seen that if we do so, that these patients benefit from a clinical point of view.
So, Jörg, can you tell us about the vena contractor?
Yeah, the lightning vena contractor was now 0.5. So it was 0.4 on the left image and 0.6 on the right. So that means we decreased that from 1.5 to 0.5. At this, we will have a little bit leakage here as well. But you see, that is really very minimal. because that is the commissural view. And if you look at the corresponding X-plane view at 90 degrees here, it's hard to measure a vena contracta, if you agree. So, and I will do the PISA measurement as well. Just wait the bubbles to disappear. So that is one. Now we measure the.
So Nicolas, what do you think?
Velocity.
I think it's impressive, but I think we used it from torrential to
So I go back and measure.
I would still call this severe TR. But as we discussed earlier on, a reduction from torrential to severe might have significant effects in terms of quality of life and might, for instance, keep ascites away and bring the patient's appetite back and so on and so on. So I think it is quite a very nice demonstration of where we're going in the tricuspid space.
Yeah, and I think that differentiation between the severe and the torrential is clinically something that needs more data, but at least initially seems to make some sense. Particularly given the substrate of this individual patient.
So we have half the error.
But you definitely
effective regurgitation orifice is 0.3.
There are some signals in the literature that you know even mild reductions in severe TR has a clinical effect. But I agree with you. We need
particularly done without a surgery.
Data. Yeah, exactly.
And done without the risk of a surgery, because if you had a surgery with this result, that would be a lot of risk up front, whereas this is different.
And that is an important concept. I think this patient is not at risk or not at a significant risk during the procedure. Open heart surgery in this patient is almost a no-go.
Maybe we can.
So Philip, is that okay with you? Thank you so much for this demonstration. Go ahead.
Yeah, we released the device. Let's just have another look at color, and then also we go back to transgastric. Also to see maybe there is a possibility to implant a second one, a third one. I don't think so, but let's see. Maybe let's have another transgastric view on that. I think it's important to set expectations right, and maybe we haven't done that before, but yeah, we started with massive and not with severe, which makes it more difficult. We have very high RV pressures, so even if we leave behind small coaptation defects, there's still some color going through and some blood. I think this is important. But as said before, when we reduce it by 2 grades, we certainly see clinical benefit. Okay, so I mean, from an anatomical point of view, I think that looks good. The devices are very stable. Can we see color here once again, please? Okay, and can we see just the last view? Can you show us the initial TR? And then I think we are ready to.
Excuse me, just a second.
Maybe we should also come back to the numbers. So we had a vena contractor of 1.5 before, and we went down now to 0.5, which is a significant reduction. It's still moderate or more severe, but now we have to look if there's a possibility to maybe even reduce it further. And I think this is what we have to figure out.
All right. Well, with that, I think we're going to leave because we have to wrap up over on this end. But thanks so much for that great demonstration to you and the whole team, the new device as well. And with that, we'll end this live case transmission. And both cases, both from Emory and from Leipzig, were fantastic. Thanks so much. Nick, I'm going to hand it over to you to wrap up the day.
Thank you very much. Thank you.
Thank you. Okay, yeah.
So that's the end of a very exciting day one of TIO, focusing on structural heart interventions. If I highlight for me in the first segment, focusing on transcatheter valve implantation, I would say that the live cases nicely demonstrated different valve platforms, but especially also the controlled and relatively easy way on how we can these days replace a valve through a transfemoral approach under local anesthesia. I think the two different concepts totally different, but also very effective in their own way. That said, I think the educational part with the presentations clearly demonstrated that we have randomized trials, but in selected cases. And there are some unknowns. What about bicuspids? And what about remaining issues related to TAVI that definitely need to be resolved as we are moving to younger and lower risk patients? The second part of today's session was focusing on the tricuspid and mitral space. That's a totally different arena. I think the live cases there were highlighting the complexity of these patients. I think both cases involved patients that were turned down by the surgeons, so there were no other options than a transcatheter approach. The case from Emory was very complex, but it clearly demonstrated fundamental concepts within transcatheter mitral valve replacement, and I think how they addressed the risk for LVOT obstruction with their antegrade lampoon technique was magnificent. In terms of tricuspid therapies, I think we are opening up a new set of opportunities for patients with tricuspid regurgitation. I think the TriClip technique is a very controlled and very safe technique, as was nicely demonstrated by Philip Lurz from Leipzig. And don't forget, surgery comes with a very high mortality. In-hospital mortality of 10% is quite significant in these patients. That said, I think from the educational segment of the tricuspid and mitral interventions, I think it's clear and it's fair to say that the majority of these patients are sent to us as interventional cardiologists too late in the game. We need to create some sensibility among the heart failure community and among the general cardiologists that we need to see these patients at an earlier stage, because then transcatheter-based valve repair results will become even better. So with that, I would like to thank the audience for participating in day one. I would like to thank the chairs and the faculty for their participation. If you want to have more in-depth analyses on structural heart interventions, I'd like to refer to you to TVT Connect that is about to start next week and will be a 10-day event with more focused in-depth analyses of other topics within the structural heart valve space. Please stay tuned tomorrow for day 2 of TIO. Day 2 will have a focus on complex coronary interventions. We have one section on CTOs and one section on calcified lesions. You don't want to miss this, and I'm looking forward to see you tomorrow. Have a great evening. Bye-bye.